6 dangerous side effects of statins. You should never ignore. Your doctor prescribed you statins to protect your heart, but what if the very drug designed to save you from one disease could significantly increase your risk of developing a completely different, life-changing one? In our last video, we covered the common, often frustrating side effects of statins. But today, we are going into the red zone. We're talking about the side effects that are not just annoying, but genuinely dangerous. Statins are one of the most prescribed classes of drugs in the world, with over 40 million Americans taking them to lower cholesterol. And they are incredibly effective at that job. But the conversation often stops there. The decision to prescribe a statin often hinges on a concept called number needed to treat, or NNT. You're told that for a certain number of people who take the drug, one major cardiovascular event will be prevented. That sounds great, but what about the other side of that statistic? What about the number needed to harm? The fact is, for every person helped, a certain number will also experience significant harm. The information you receive almost always champions the first number while glossing over the second. This video is about giving you both sides of the equation. In this video, we are exposing the information that often gets left out of that 15-minute doctor's appointment. We are breaking down 6 dangerous side effects backed by scientific research that you should never ignore. So, if you're taking a statin, this is information you can't afford to miss. Please note, this video is for informational purposes only and not a substitute for medical advice. All information provided has been carefully verified. Source links are available in the description. Let's dive into the first dangerous side effect, acute kidney injury. Acute kidney injury, commonly abbreviated as AKI, represents one of the most serious yet under-recognized complications of statin therapy. This condition occurs when your kidneys suddenly lose their ability to filter waste products from your blood effectively. The medical literature reveals a startling 34% increased risk of hospitalization for AKI within the first 120 days of starting high-potency statins, with studies tracking over 128,000 new statin users over a median follow-up period of 4.6 years. High-potency statins include medications like atorvastatin at doses of 40 to 80 milligrams daily and rosuvastatin at 20 to 40 milligrams daily. These powerful cholesterol-lowering drugs can trigger kidney damage through 2 primary mechanisms. Research indicates that 47% of new statin users are prescribed high-intensity regimens, while 46% receive medium-intensity protocols. The first involves a condition called rhabdomyolysis, where muscle tissue breaks down rapidly, releasing proteins that overwhelm and damage the kidney's filtering units, called nephrons. The second mechanism involves direct tubular toxicity, where statins directly damage the tiny tubes within your kidneys responsible for processing waste. This damage can occur even without muscle breakdown. Your kidney tubules contain specialized cells that can be particularly vulnerable to the cellular changes statins induce. The signs of AKI can be subtle initially, but become progressively more concerning. Early symptoms include decreased urine output, which you might notice as urinating less frequently or producing smaller volumes of urine than usual. Swelling in your legs, ankles, or feet develops as your body retains fluid it cannot properly eliminate. You may experience fatigue that seems disproportionate to your activity level. More advanced signs include nausea, vomiting, and confusion as waste products accumulate in your bloodstream. Some patients report a metallic taste in their mouth or persistent hiccups. Shortness of breath can develop as fluid accumulates in your lungs due to your kidney's inability to maintain proper fluid balance. 2. Hemorrhagic stroke. Hemorrhagic stroke represents a devastating neurological emergency where blood vessels within your brain rupture, causing bleeding directly into brain tissue or surrounding spaces. While statins effectively reduce ischemic stroke risk by approximately 15 to 20%, with a pooled relative risk of 0.80, they paradoxically increase hemorrhagic stroke risk by 73% in patients with a history of cerebrovascular disease, with a pooled relative risk of 1.73. This creates a complex clinical dilemma requiring careful risk-benefit analysis, particularly given that hemorrhagic strokes account for approximately 20% of all strokes, while ischemic strokes comprise 80%. The mechanism behind this increased bleeding risk involves statin-induced changes to blood clotting and blood vessel integrity. Statins reduce platelet aggregation, which means your blood cells responsible for clotting become less sticky and less likely to form protective clots. Additionally, statins deplete cholesterol from cerebral blood vessel walls, potentially weakening their structural integrity and making them more prone to rupture under pressure. This risk becomes particularly pronounced with moderate to high-intensity statin therapy. Moderate-intensity statins include atorvastatin 20 mg or simvastatin 40 mg daily. High-intensity regimens involve atorvastatin 40 to 80 mg or rosuvastatin 20 to 40 mg daily. The higher the dose, the greater the potential impact on bleeding risk. Recognizing hemorrhagic stroke symptoms requires immediate medical attention, as every minute counts. The most common initial symptom is sudden, severe headache that patients often describe as the worst headache of my life. This headache typically develops rapidly and differs significantly from typical tension or migraine headaches. Nausea and vomiting frequently accompany this severe headache. Neurological symptoms develop based on the bleeding location within your brain. Sudden weakness or numbness affecting one side of your body is common, often involving your face, arm, and leg simultaneously. Speech difficulties range from slurred speech to complete inability to speak or understand language. Vision problems can include double vision, partial vision loss, or complete blindness in one or both eyes. Altered consciousness represents another critical warning sign. This can range from mild confusion and disorientation to complete loss of consciousness. 3. Cataract formation. Cataracts develop when the naturally clear lens inside your eye becomes cloudy or opaque, interfering with light transmission to your retina and gradually impairing vision. Epidemiological studies consistently demonstrate 9 to 27% higher odds of cataract diagnosis among statin users compared to non-users, particularly after 2 or more years of continuous therapy. However, the relationship between statins and cataract formation remains complex and somewhat controversial. The proposed mechanism centers on cholesterol's critical role in maintaining lens membrane fluidity and transparency. Your eye's natural lens contains specialized cells called lens fiber cells that must remain perfectly transparent throughout your lifetime. Recent comprehensive studies analyzing 21 clinical trials involving over 140,000 patients have provided additional evidence supporting this association. These cells depend on precise cholesterol concentrations within their membranes to maintain their unique optical properties. Statins, by dramatically reducing cholesterol synthesis, may disrupt this delicate balance. When cholesterol levels within lens fiber cells drop significantly, the cell membranes can become less flexible and more prone to protein aggregation. These protein clumps scatter light passing through the lens, creating the characteristic cloudiness we recognize as cataracts. This process typically occurs gradually over months to years, making it difficult to detect early stages without professional eye examination. The earliest signs of cataract development often involve subtle changes in vision quality that you might initially attribute to normal aging or eye strain. Colors may appear less vibrant or somewhat faded, particularly blues and purples, which become harder to distinguish. You might notice increased difficulty reading small print or performing detailed tasks that previously posed no problem. Night vision deterioration represents another early indicator of cataract formation. Driving at night becomes increasingly challenging as oncoming headlights create excessive glare or develop halos around light sources. 4. Sexual dysfunction. Sexual dysfunction represents one of the most underreported and undertreated side effects of statin therapy, affecting an estimated 1 to 5% of male users, according to clinical studies, though real-world surveys suggest rates may reach 10% among high-dose statin users. Large-scale meta-analyses of randomized controlled trials have documented muscle symptoms in 12.7% of statin-treated subjects, compared to 12.4% of placebo-treated subjects, suggesting that sexual dysfunction may be similarly underreported in formal clinical trials. This condition encompasses multiple aspects of sexual health, including decreased libido, erectile dysfunction, and impaired arousal. The psychological and relationship impacts often extend far beyond the physical symptoms themselves. Statins interfere with sexual function through 2 primary biochemical pathways. First, they reduce testosterone synthesis by limiting cholesterol availability, which serves as the essential building block for all steroid hormones, including testosterone. Lower testosterone levels directly impact sexual desire, arousal capacity, and overall sexual satisfaction. Second, statins disrupt the nitric oxide pathway within blood vessels, particularly those supplying the genital region. Nitric oxide serves as a critical signaling molecule that relaxes smooth muscle within penile blood vessels, allowing increased blood flow necessary for achieving and maintaining erections. When statins impair this pathway, the result is compromised vascular function, affecting erectile capacity. This mechanism explains why erectile dysfunction often develops gradually rather than suddenly, as vascular changes accumulate over time. The early signs of statin-induced sexual dysfunction typically begin with subtle changes in sexual desire and interest. You might notice decreased spontaneous sexual thoughts or reduced interest in sexual activities that previously brought pleasure. Morning erections may become less frequent or less firm, often serving as an early indicator of developing erectile dysfunction. 5. Alopecia. Alopecia, or hair loss, represents a rare but psychologically distressing side effect of statin therapy, documented in numerous case studies and clinical reports. This condition typically develops within 3 to 6 months of initiating statin treatment, suggesting a direct relationship between the medication and hair follicle function. Recent studies examining statin toxicity indicate that observational studies suggest it occurs in 10% to 15% of patients, with clinic data putting it as high as 30% for overall statin-intolerant symptoms, though hair loss specifically remains much rarer. The psychological impact often exceeds the physical severity, affecting self-esteem, social interactions, and overall quality of life. The mechanism underlying statin-induced alopecia involves disruption of cholesterol synthesis within hair follicles, where cholesterol plays essential roles in maintaining cellular membrane integrity and supporting the rapid cell division required for hair growth. Hair follicles rank among the most metabolically active tissues in your body, with hair matrix cells dividing every 12 to 24 hours under normal circumstances. This rapid turnover makes them particularly vulnerable to metabolic disruptions. Additionally, statins interfere with isoprenoid pathways that regulate keratinocyte function. Keratinocytes are the specialized cells that produce keratin, the protein that forms the structural foundation of your hair shaft. When these pathways become disrupted, keratinocyte function declines, leading to weakened hair structure and increased susceptibility to breakage and loss. The clinical presentation of statin-induced alopecia varies considerably between individuals. Some patients experience diffuse hair thinning, where hair loss occurs uniformly across the entire scalp rather than in specific patterns. This type of hair loss often goes unnoticed initially because the thinning occurs gradually and evenly. You might first notice increased hair on your pillow, in your shower drain, or on your hairbrush. Others develop more noticeable patchy hair loss, where distinct areas of the scalp become visibly thinner or completely bald. These patches can appear anywhere on the scalp, but commonly affect the crown or temples initially. The remaining hair in unaffected areas typically maintains normal thickness and appearance, creating a stark contrast with the thinned regions. 8. Hypersensitivity reactions. Hypersensitivity reactions to statins represent potentially life-threatening immune-mediated responses that occur in fewer than 1 in 10,000 patients, but require immediate recognition and treatment. These reactions develop when your immune system mistakenly identifies the statin molecule as a foreign invader, triggering a cascade of inflammatory responses that can rapidly become systemic and dangerous. Research from comprehensive safety analyses indicates that while statins have significant mortality and morbidity benefits for both primary and secondary prevention, severe hypersensitivity reactions remain among the most concerning adverse events requiring emergency intervention. The severity can range from mild skin reactions to full anaphylactic shock. The pathogenesis involves hapten formation, where statin molecules bind to endogenous proteins, creating new molecular complexes that your immune system doesn't recognize as self. This triggers both immediate and delayed hypersensitivity reactions mediated by different components of your immune system. Immediate reactions involve immunoglobulin E antibodies and mast cell degranulation, releasing inflammatory mediators like histamine throughout your body. These inflammatory mediators cause widespread vasodilation, increased vascular permeability, and smooth muscle contraction in various organ systems. The result can include cardiovascular collapse, respiratory compromise, and severe skin reactions. Delayed reactions involve T-cell mediated responses that can persist for days to weeks after exposure, creating ongoing inflammatory damage to affected tissues. The earliest signs of hypersensitivity reactions typically manifest as skin changes that can appear within minutes to hours of taking your statin dose. A pruritic maculopapular rash, often develops first, appearing as raised, itchy red bumps scattered across your trunk, arms, or legs. This rash may start small and localized, but can rapidly spread to cover large areas of your body surface. Urticaria, commonly known as hives, represents another early manifestation consisting of raised, itchy wheals that can appear and disappear rapidly across different body areas. These wheals typically have well-defined borders and blanch when pressed. They can range from small spots to large patches, covering significant portions of your skin. Thank you for watching and supporting our work. If you found this helpful, please give it a like and subscribe for more content like this.